patients with cerebrovascular accident in community setting. 8 is the question and answer session, and the last is closing. Entering the first agenda, let's open the program this morning by praying, which will be led by Bima Yuna Aji Susanta. To Bima Yuna Aji Susanta, time is yours.
Warahmatullahi wabarakatuh. Let's take a moment together. Bless me to God that our activities today are blessed and can run smoothly. Prayer will be led by Islam, for others being requested to adjust. Bismillahirrahmanirrahim. Alhamdulillahi rabbil alamin. Wassalatu wassalamu ala asrafil anbiya'i wal mursalin. Sayyidina wa habibina wa syafi'ina wa maulana Muhammadi wa ala alihi wa sahbihi ajma'in. O Allah, Lord Almighty, with all humility, we that gathered in this place, praise and gratitude for the presence of you, over the blessings and grace that you had given us. O Allah Almighty, the most compassionate all grace and graces of you. Today we want to organize the activities of the International Seminar 2022. Bless us, give us guidance to be able to carry out activities sincerely, well and correctly according to the path you reday, and make it all values of worship and values that are useful to us. O Allah, one and most united, we ask to make this even a momentum to be able to glue the sense of unity and integrity between us. Keep us away from just and hostility. Make our determination as a pioneer young man to build a country and useful for religion, state, and nation. O Allah, God is Almighty, that all our sins, the sins of our mothers, our teachers, and our leaders, accept our critics and struggles and place us and they are all the protection of your grace and forgiveness. O Allah, Ya Mujib, you grant a prayer, permission our prayers and application. Rabbana atina fid dunya hasanah wa fil akhirati hasanah wa qina azabannar. Subhana rabbika rabbil izzati amma yasifun. Wassalamun alal mursalin. Walhamdulillahi rabbil alamin. Amin ya rabbal alamin. Wassalamualaikum warahmatullahi wabarakatuh.
Ladies and gentlemen, now we move to the second agenda. Let us rise for the listening of the Indonesian National Anthem, Indonesia Raya, and Hymn of Health Polytechnic of the Ministry Malang. All participants are kindly requested to sit properly. Thank you, all blessed participants. To begin the opening ceremony of the International Seminar 2022, here's the report from the Chief of the Organizing Committee. Tupugu Hananto, time is yours.
Assalamualaikum warahmatullahi wabarakatuh. Good afternoon and welcome everyone to International Seminar 2022. We are excited to have you here. This will be an opportunity for us to learn from each other and grow together. The Honorable Mr. Dr. Muhammad Wildan, as the Director of Nursing Department, Health Polytechnic of the Ministry Malang. Represented by Mr. Rudy Harmano, SCUP Nurse MCUP, as Secretary of Nursing Department, Polytechnic of the Ministry Malang. We respect Dr. Ati Yudirnawati, SKP MPD, as Head of D3 Nursing Study Program, and we respect Mr. and Mrs. Lecturer of Nursing Malang, staff employees, and VIP guests. Don't forget the participant in the 2022 International Seminar who I care about. Me, as the chairman of the committee, will submit several reports related to this activity. The first one will be discussing about rehabilitative and integrative therapy for CVA bleeding and giving you practical tips that can you use in your own work. But before that, let's take a moment and let me introduce our guest speaker. The first speaker we have Miss Jesusa Magno, MN from Philippines, and the topic she brought is focusing on updated nursing intervention for patients with CVA in hospital settings. And the second speaker we have Mrs. Sharmila Gopala Krishna Pillai from Malaysia, and the topic she brought is also focusing on physiotherapy program for patients with CVA in community settings. I want to thank you for our speakers for taking the time to share their knowledge and giving real-life examples. We do not forget to thank the supervising lecturers and also the IT team in the Malang Nursing Department who took the time to guide us from the start until this event was held. We also thank to all participants who have joined this event. We hope that the knowledge you gain can be useful. Me, as the chairman of the committee and the representative of the committee, apologize if there are still many shortcomings in carrying out this webinar. I hope that the knowledge we can get in this event can be useful for our future career. We'll also take questions throughout the webinar, so please feel free to type them in the chat box. And without further ado, let's start. Wassalamualaikum warahmatullahi wabarakatuh.
Thank you to Pugu Hananto for the report. Ladies and gentlemen, now we move to the next agenda. It is the welcoming speech and opening by Mr. Rudy Hamarno as Nurse MPOT, as Nursing Department Secretary of Health Polytechnic of the Ministry Malang. To Mr. Rudy Hamarno, time is yours.
Okay, thank you, Ms. Shiva. Assalamualaikum warahmatullahi wabarakatuh. Good afternoon, Honorable Head of Diploma 3 Nursing Program of Malang, Dr. Ati Yudirnawati, MPD. Honorable the Speaker, the first Professor Jesusa M. Magno, MN from Philippines. The second, Sharmila Gopala Krishna Pillai from Malaysia. It's nice to meet you. Honorable Academic Subcoordinator, Ms. Ira Rahmawati, Honorable all lecturer in the Nursing Department, Honorable Head of the Student Association of Diploma 3 Nursing Program or HMP, and honorable the committee and all the participation. Alhamdulillah, we give thanks to Allah Subhanahu wa Ta'ala so that we can carry out this international seminar. The theme is Rehabilitative and Integrative Therapy for CVA bleeding. I think it's very appropriate and very interesting because it's in accordance with the vision of the Diploma 3 nursing program and current condition in Indonesia that cerebrovascular accident is increasing prevalence every time and every years, and current and is one of the government's program, especially the promotion and prevention, but also need treatment and rehabilitation. The student must have knowledge and enough skill how to manage and rehabilitate CVA in hospital and community setting. So one more, I say thank you for the head of Diploma Nursing Program of Malang, and thank you the speaker who has joined and shared knowledge with me, with the nursing department of Health Polytechnic of Chemistry Malang, and thank you for my student. Congratulations and success for our, and by saying Bismillahirrahmanirrahim, the event begin. I think it's all. Thank you. Wassalamualaikum warahmatullahi wabarakatuh. Good afternoon.
Thank you, Mr. Rudi Hamarno, for the very warm welcome. Well, this is what we are waiting for, entering the main event of the International Seminar 2022, which will be covered the speech by several speakers. In this agenda, will be handled by Ms. Ira Rahmawati, MNSJ, as moderator. Before the moderator takes over this event, let me read the moderator's CV first.
Kenapa itu? Ini bukan. Bukan begitu ya.
Okay, continue.
Her name is Miss Ira Rahmawati. For her educational background, on 2002 to 2006, Nursing Faculty at Pajajaran University Bandung. On 2006 to 2007, Nursing Professional Program at Pajajaran University Bandung. On 2015 to 2016, Master of Nursing Science at the University of Adelaide, South Australia. And for her work experience, on 2016 to 2017, at Premier Surabaya Hospital, position emergency room nurse. At 2017 to 2019, at Esa Unggul University Jakarta, position as a lecturer. On 2019 until now, at Health Polytechnic of the Ministry Malang, position as a lecturer. Well, now it's time for the moderator to take over this event. to Ms. Ira Rahmawati, MNSJ. Time is yours.
Okay, thank you, Ms. Siva. Good afternoon to all participants of this virtual seminars. We are delightful to have you all here. So today we will have special lectures and interesting discussion on managing patients with stroke. As we know that managing and caring for patients with stroke remain a great challenge for nurses and also for other healthcare team because it requires fast response, multidisciplinary approach, and also long-term care. So, but first I would like to extend my very warm welcome to our speakers. As it's mentioned before, we have two experts today who will talk about managing patients with stroke in the hospital and also in the community settings. And for the first session, we will have Professor Jesusa M. Magno from the Philippines, who will talk about update nursing intervention for patients with cerebrovascular accidents in hospital settings. Hello, Professor Jesusa, are you with us? Yes. Professor, are you with us?
Hello, good afternoon.
Yes, good afternoon. Welcome. We are honored to have you here, Professor.
Thank you so much. Thank you
Yes.
so much.
Yes. Before we begin the lecture from the Professor Jesusa, to all participants, later we will have a discussion session, and you will be there will be opportunity for you all to ask questions directly to Professor Jesusa by raising your hand or just type in the chat room. Before we begin, allow me to read our speaker's profile. Professor Jesusa M. Magno, did I pronounce your name correctly, Professor? Jesusa, is it?
Yes, Ma'am Ira, that's correct. Jesusa.
Okay, Jesusa, yes. She was born in Carigara, December 25th, 1960. And then she graduated from Master of Art in Nursing from University of San Carlos in 2009. And she did her Bachelor's of Science in Nursing in Concordia College Manila in 1985, and then also graduate nursing in 1982. Next, and at current, she is an assistant professor too at Visayas State University. And then from 2018 until 2020, she was the Dean of Visayas State University. And then she worked as staff nurse at Vallarta General Hospital in 1987 until 1992. And then also she was a rural health professional program nurse, yes, in Ministry of Health, Tacloban City. And then next, she is also a member of various organizations, which include the Philippine Nurse Associations, PNA North Little Chapter as a president, and also Maternal and Child Nurses Associations, Association of Dean of Philippine College of Nursing, and Association of Nurse Supervisor and Administrators of the Philippines. Well, Professor Jesusa, we have about 1 hour for the lecture, and after that we have 45 minutes for the discussion. And time is yours, please.
Thank you so much, Ma'am Ira. Thank you so much, everyone, the organizers particularly. I am pleased to be back to Health Polytechnic of Malang, and again to discuss with you all the updates regarding the care of patients with cerebrovascular accidents. We have had a meeting with Dr. Kisa Bahari when they were here. And so we really had to have some plans in terms of the educational or academic endeavors in which there will be an exchange of the students or the faculty or the lecturers and so on and so forth. That was quite a very good engagement, as we already have planned our futures in coming up with or achieving excellence in nursing education in the region. Okay. So I proceed with my presentation. Can I have my first slide, please? Hello.
Ya, I'm sorry. PPT-nya bisa di share screen? Please wait for a moment, Professor.
Sure.
It seems there is a trouble from the committee. Let me try. It's already in. Yes.
Okay, so thank you so much. And my presentation is cerebrovascular diseases because this comprises the three types of CVDs considered as the CVA. Now we have the stroke, TIA, transient ischemic attack, and cerebral aneurysm. Next slide, please. I hope that my presentation will be able to answer the following questions. Number one, what are the causes of and risk factors of CVA or stroke? So we will have to focus our discussion in here. CVA is just one of the three types of CVDs. Okay. The second question is, what are the significant clinical findings evident in a client with CVA stroke? Number three is, which diagnostic tests are most appropriate to aid in the final diagnosis of the disorder? And number four is to discuss nursing interventions with and or through interprofessional collaboration. Next slide, please. All right, for a start, we'll have to remind ourselves with the parts of the brain, because CVA or the stroke is a disease process or a condition that affects the brain tissues and the blood vessels as well. So we need to say that the brain tissues would be deprived of oxygen, and the blood vessels may either have obstructions in the form of thrombosis or embolus, or it can have rupture. So that is why we have two types of CVA. First is the ischemic, brought about by oxygen deprivation into the brain tissue. And the second one is hemorrhagic, brought about by the rupture of the blood vessel. All right, so just feel free to see my slide in here, and we will be reminded as to the different functions of each lobe of the brain. Okay, next slide, please. All right, so in here we have the bottom view of the brain showing the blood supply or the arteries supplying the brain tissue or the brain itself. All right, so we have the anterior cerebral artery. Okay, so this bigger picture is found at the middle or the portion, middle or the center portion of the brain, seen from the bottom. Okay, so the middle cerebral artery, which are the most commonly, or which is the most commonly affected blood vessel in CVA. And then we also have the internal carotid artery, the second that is frequently affected with the CVA. Now, there might be a thrombosis or an occlusion in the internal carotid artery. And then we also have the posterior communicating artery, the posterior cerebral artery, the basilar artery, and of course the circle of Willis. There is one condition which affects also the vasculature that supplies or that surrounds the circle of Willis. So from among those conditions, we always consider that as the most fatal as it affects the circle of Willis. Of course, we know what are the structures that are in the circle of Willis. Okay, next slide, please. Okay, so these are the blood vessels or the arteries that I was saying earlier and are frequently affected when there is CVA. Okay, these are cerebral arteries which are located inside the cerebrum of the brain. So meaning to say, these are the blood vessels that supplies blood or oxygen and nutrients into the brain tissue. So examples in here, we have the anterior cerebral artery, the middle cerebral artery, and the posterior cerebral artery. Now we have also another set of arteries supplying the brain, the pre-cerebral arteries. So we need to say, these are blood vessels that are not embedded in the brain tissue. Okay, so that leads to the cerebrum of the brain but are not located within the brain. So externally located. So examples in here, we have the vertebral artery, the basilar artery, the carotid artery. Okay, so I have in here listed, I have listed the two most commonly or frequently involved blood vessels in cardiovascular accidents. So it's always the middle cerebral artery and the internal carotid artery. Earlier on, I have pointed this out in the picture that we have shown in one of the slides. Okay, next slide, please. Okay, now when we say cerebrovascular diseases, is a group of disorders resulting in interruptions of blood supply to the brain. Okay, so interruptions of blood supply in CVDs, cardiovascular diseases, again, could be brought about by thrombosis, by embolus, or by occlusion or narrowing of a major blood vessel that supplies the brain. Of course, we are familiar with atherosclerosis, with arteriosclerosis, right? So well, the terms are not foreign to us. So we have types of CVDs, CVA, also known as the stroke. We have the TIA, transient ischemic attack, and cerebral aneurysms. Okay. Now, when we say cerebral aneurysm, this condition being part of this form part of the CVDs is secondary to congenital anomalies. Now, I'm talking about congenital malformations or congenital anomalies in the blood vessels supplying the brain. I'm sure we are familiar with aneurysms or a portion of the blood vessel that weakens because of the congenital malformation. We are also familiar with the AV malformation. So these are examples or typical examples of congenital anomalies that could result to cerebral aneurysm. Next slide, please. Okay. So we have the etiology. What really are the specific causative factors or agents that causes CVA, TIA, and cerebral aneurysm? All right, so let's have to point out one by one. Again, to mention thrombus and embolus. Now in your books, or in some other references, it may say thrombosis, still the same. I'm sure also we are familiar with how thrombosis and embolus differs, right? So these are not terms, again, which are foreign to us. The most commonly affected blood vessel when there is CVA is the middle cerebral artery. Now, this type of CVD or cerebrovascular disease can cause permanent neurologic disability. Okay, so meaning to say, it is widespread and quite fatal. So meaning to say, again, that if your patient will have CVA, rehabilitation or rehabilitative activities should be engaged in by your patient in order to, again, maximize the remaining potentials of the patient. So we will not develop in here dependence, but we have to develop independence on the part of the patient as well as the family. Okay. The second one is the TIA, also known as the transient ischemic attack. Ischemia. So when we say ischemia, that is again decreased blood supply to the brain, depriving the tissue of adequate blood supply. So we're familiar with tissue perfusion. So when we say tissue perfusion again, that is adequate blood supply to the brain tissue so as not to cause ischemia and eventually permanent damage. Okay. So ischemia brain tissue due to occlusion of intracranial or extracranial artery by arteriosclerosis. In some references class, they would also include atherosclerosis as one etiologic factor in TIA. Okay. Then we have the most commonly affected blood vessel in TIA, that is the bifurcation of the common carotid artery. So again, earlier on, you were shown a slide with the common carotid artery and its bifurcation. So the branch, the point in which the common carotid artery would divide or would branch into becoming the upper and the lower portion, or the internal and external carotid artery. Okay, as far as congenital aneurysm is concerned, it is associated with congenital softening of the vessel wall. So these are already given earlier. The blood vessel that is commonly affected with cerebral aneurysm is the anterior portion of the circle of Willis. Okay, again, this was shown earlier. Next slide, please. Okay, now let's move on to the risk factors in the development of CVA. Now, I have divided this into about 3 major factors. So first are diseases. Okay, so why do we have to include these diseases as the risk factors for CVA? Okay, so hypertension. In our previous lectures or in your lecture for the medical surgical nursing, it is already a common knowledge that hypertension is an elevation of the blood pressure because there is always a high pressure exerted in the blood vessels, and this is brought about by some other factors just like atherosclerosis, arteriosclerosis, and then the occlusions that can be formed secondary to platelet aggregation or fat plaques accumulation, and or we also have the injury of the endothelial lining that gradually gathers the platelets or the thrombus, making up thrombus aggregation or platelet aggregation, and thus causing again another narrowing. So all these conditions can place an increase in pressure along the vasculature or the vascular bed, giving rise to increased blood pressure. So when there is increased blood pressure, for sure there will always be vasoconstriction. If there is vasoconstriction, that again would result to an elevated pressure in the blood vessels, and in the long run, it can predispose the individual to have a ruptured blood vessel, and then a thrombus formation and decreased blood supply to the brain. Okay, it should be remembered that all these conditions would always result to decreased tissue perfusion to the brain tissue. Okay, the second disease is diabetes mellitus. All right, again, a common knowledge that when there is diabetes mellitus, there is always viscosity of blood. Okay, it is brought about by the increase in blood glucose level, making up the characteristic viscosity of the blood. Okay, if it is viscous, therefore, there will have to have a decrease in circulation of the blood, some of which will have stasis, and then with it is thrombus formation, narrowing or occlusion of the blood vessel, and therefore decrease blood supply to the brain. Okay, now for the third disease process, we have myocardial infarction. Okay, now when we say myocardial infarction, there is always a decrease in cardiac output. So therefore, decreased oxygen supply, decreased tissue perfusion, stasis of some blood that will form thrombus, and again occlusion, thus decrease tissue perfusion to the brain tissue. Okay, and for atherosclerosis, okay, now atherosclerosis is narrowing of course, the diameter of the blood vessel, which will predispose the individual to have decreased cardiac output, and then again, decreased tissue perfusion. In most cases, it can also predispose the individual to have stasis, thrombus formation, and again, decreased blood supply to the brain. As far as congestive heart failure is concerned, same with your myocardial infarction, there is always decreased cardiac output. Okay, when there is decreased cardiac output, meaning to say that there will be congestion of blood either at the arterial level or at the systemic level. So with that, stasis, thrombus formation, there will be thrombus formation, and again, it will interrupt or hinder the blood supply to the brain. Okay, so these are all for the diseases. Were you able to get it, class? Hello? Please caution me if I am talking fast.
It's okay. It's all right.
Okay.
Yes.
Thank you. Thank you. Next slide, please. All right. The second classification is lifestyle. All right. So we know that in lifestyle, it always, again, predisposes the client to have hyperlipidemia, right? Okay. So let's start with obesity. So when you say obesity, there is always an increase in the concentration of cholesterol, either at the hepatic level or the liver or in the blood vessel. So when there is an increase in cholesterol or the lipids that we think about, it can again, going back to your atherosclerosis or arteriosclerosis, that can cause plaque formation, aggregation, narrowing of the blood vessel, thus decrease blood supply to the brain as well as to the vital systems. Okay, so that's obesity. All right. Obesity can also be associated with physical inactivity. All right, so it's in here, physical inactivity. Right. So number 2, lifestyle is stress. All right. Now, in almost all cases in medical, surgical, nursing, when we discuss, we always attribute stress to most of them. Okay. Now we'll try to focus on CVA. Why is this related to CVA development? All right. In stress, it is both the mental and the physical aspect that are in compromise. Okay. You have, of course, we are familiar with the SAMR response. We are familiar with what do you call this? We are familiar with your not the inflammatory response, but we are familiar with how stress would affect the cardiac system or the heart system particularly. Okay, so let's focus. Stress can increase the workload of the heart. Okay, it can increase oxygen demand to increase blood supply. Okay, however, because of interruptions, because of hindrances in terms of the normal flow of blood in the blood vessels, there will always be a decreased oxygen supply because of vasoconstriction. It is always associated with stress. Now with that, if there is decreased or if there is a vasoconstriction, the end result of that is always decreased tissue perfusion. So it's almost similar with your atherosclerosis and arteriosclerosis, but in stress, it is that there is almost about a higher percentage of vasoconstriction. Okay, so that's tension, what else? Your physical stress, emotional stress. And so this again can cause CVA because of the pathophysiologic process that it brings about. Okay, now in terms of physical inactivity, meaning to say that inactive, living a sedentary lifestyle. If that is that way, therefore the circulation is not enhanced, and that predisposes the client to have stasis formation. Okay, or stasis of blood either the arterial or the systemic level. So when there is stasis again, it will result to thrombus formation and again occlusion and decreased blood supply to the brain. As far as cigarette smoking is concerned, of course, we are familiar with the tar, with the nicotine, that when absorbed into the bloodstream will always attract the platelets and then make an aggregate in the endothelial lining of the blood vessel, which would eventually cause injury in the lining and thus further aggregation of platelets and other blood components, thus forming a bigger thrombus or embolus. So again, another occlusion that would predispose the client to have vasoconstriction and therefore decreased blood supply to the vital organs, particularly the brain. Okay, and the same manner as when the person is engaged or is having this ingestion of alcohol, and of course the use of contraceptive pill. Okay, what particularly contraceptive pill? Why is it considered as a risk factor for CVA? Because contraceptive pills, the estrogen content of that is considered to have or to increase cholesterol uptake. So that is why if the mother is supposed to have this as their family planning method, it should be that she has to have a thorough physical examination. So remember that when there is an increase in cholesterol uptake, that again can cause occlusion in the blood vessels. Now, the estrogen content or the contraceptive pill itself can increase pressure in the blood vessels. And again, another condition, which is CVA. It's always decreased blood supply. All right. Worst of that class is it can cause rupture of the blood vessel and then again further thrombus formation and stasis. Now, patients or mothers who is supposed to have the contraceptive pill as their option for family planning method, if it is practiced, so we need to have the thorough checkup. So I have to monitor first the blood pressure of the mother, okay, and then check for varicosities. So the mother should never have varicosities. Why? Because the estrogen again can cause an increased pressure in the blood vessels that would eventually cause rupture and then extravasation of blood into the surrounding tissue. It may not only be in some other parts of the body, but it may occur also in the intracerebral compartment. Okay. Now, if there is an intracerebral hemorrhage, we have to anticipate class for an increase in intracranial pressure. Okay. Make sure that we are still familiar with the assessment on the determination of the LOC or the level of consciousness. So we know the 5 levels of consciousness. We also are familiar with the Glasgow Coma Scale. Huh? Okay, next slide, please. Please go back. Please go back. We still have the third factors, risk factors, advanced age, gender, and race. Okay, so it says in here that males from 30 to 60, if they have CVA, it is more related to aneurysm. And if CVA would occur by the time they reach the age of 60 to 69, it is more of thrombosis or slow circulating blood volume. More common in males because males do have the higher percentage for the vices and the stress and the alcohol and smoking and so on and so forth, but of course not for the contraceptive pills. And then on record, it says in one study that CVA is also a condition or what do you call this, a disease process that is common among Asians. So we are the spared of that class. All right, next slide, please. Okay, so we go to assessment. It is always but right for us nurses to really have or to conduct the thorough history taking as well as physical examination so as to determine or identify the significant findings that we need to know in a particular disease process. All right. Some of these findings should be included in the pathophysiologic process as well as when you formulate your nursing care plan. Again, reminder that the nursing care plan should be formulated not just with the patient, but also with the family. Remember that CVA, it is a life-threatening condition, but there are also higher chances that your patient may have, of course, the full recovery of it after the rehabilitation or the rehabilitative interventions in the post-hospitalization stay. But it is again imperative that rehabilitation should start by the time the patient is on the third day of CVA. So meaning, rehabilitation starts while the patient is still in the hospital, not in the extended post-hospitalization stay. All right. So later we will know the rationale. Why should it be done earlier? All right. Going back to assessment. For nursing history, we have to, of course, we have also, we can make use of the different mnemonics. Okay, but in here, I just listed the things that we have to know. But I think, but we should always use the mnemonics. My mnemonic that is frequently used in the discussion of some diseases with my student is WhatsApp. It's WhatsApp. Okay. Now you can find this in Medical Surgical Nursing by Williams. Okay. So we have to take the history or determine the client's history or evidence of arteriosclerosis. So meaning to say, determine if the client has comorbidities or prior disorders before the CVA onset. Okay, so we have to consider arteriosclerosis, diabetes mellitus, acute leukemia, aplastic anemia, cirrhosis of the liver, recent emboli, current headaches, epilepsy, subarachnoid hemorrhage. Okay, when we say subarachnoid hemorrhage, please determine if your patient has had prior attacks. So remember that CVA, in terms of its onset, is not, well, the manifestation is not true to all individuals. No? You may be able to observe some severe manifestations in one person, but it may only be slight in another person. But still, they are already having the attack. Okay. You also have to determine the risk factors for the underlying cause of stroke. So meaning to say that it should always be a conversation or a communication, not just with the patient, but we also have to have our secondary sources in terms of taking the history of the patient. So we will not just rely on the patient because there are instances in which they would not tell the real thing. Okay, now we will be able to identify, we will be able to determine the true cause of the disease process from the secondary sources. So these are the family members, or sometimes or at times from the patient's chart itself when there was prior hospitalization. It may be that the previous condition may have bearing on the present condition of the patient. Okay, next slide, please. For the neurological assessment, because we have to classify CVA, it is really classified as a neuro disorder or neurologic disorder. Okay, as far as neurological assessment is concerned, we have to look for the focal neurologic signs. Example, the arterial syndrome. Okay, now in the arterial syndrome, the most common that we will be able to auscultate is the bruit. Okay. Class, in your assessment, do not forget the four modalities because we still have to use that one: inspection, palpation, percussion, and auscultation. In case of arterial syndrome, we have to auscultate that with the stethoscope to be able to listen if there are bruits. Okay, the bruits that we hear would always indicate that there is decreased blood supply to the vital organ, this time to the brain. Okay. Now, your patient will also be elicited with the reflexes. So it should be that a patient with CVA would have a positive Kernig and Brudzinski's sign. I'm pretty well sure that you are able to know how to elicit this one, fundamentals of nursing. Okay. So for the acute phase of the disease process, we have to ensure that the brain tissue is adequately oxygenated and to prevent further neurologic damage. So this is our goal in terms of conducting a thorough neurologic assessment during the acute phase. Again, to ensure that the brain receive adequate oxygenation. Again, this is to prevent ischemia and to prevent further neurologic damage. All right, so what are the things that we have to check for the neurologic assessment? Number one is responsiveness. Okay, changes in level of consciousness. Does the patient respond to stimuli? So again, we have to classify if your patient is conscious, if your patient is lethargic, that is in terms of responsiveness. If your patient is stupor or having a semi-comatose LOC or coma. I'm pretty sure you have the basic classification or the description of all these levels of consciousness. So again, conscious, lethargy, stupor, semi-comatose, and comatose. That's again in terms of responsiveness and or changes in LOC. Please indicate specifically what really is the response of your patient. The second one is spontaneous movement. Okay, take note. If there are changes in muscle tone, movements of the extremities, right and left, it should be that when you conduct your neurological assessment, it has to be compared with the lateral, the contralateral side, because we have to check the symmetry or asymmetry. Okay, so one extremity or one right side of the body will be compared with the left side of the body. This is in terms of the muscle tone as well as movements of the extremity. So that's the upper and the lower extremity. The body posture and the position. Okay, take note if your patient is assuming a decorticate or decerebrate position. Okay, if it is if your patient is assuming a decerebrate position, meaning to say there is abduction of the extremities away from the body. If your patient assumes the decorticate position, the extremities and the arms are adducted towards the midline. Okay, and what is common in CVA is decorticate position. All right. We also have PERL, pupillary reaction, and recording the size of the pupils. Of course, we have a tool that should be used in the PERLA. For normal, we have, of course, PERLA, pupils equal reactive to light, PERLA. All right, a reaction to light and accommodation. Okay. Now the skin should also be checked for temperature, okay, by touch. Do not use your palm when you try to check the skin temperature by touch, but instead you have to make use of the anterior. All right. And then the moisture and the color of the skin. Now this would also tell us about the hydration status. The hydration status of the patient. Okay. Another component in your neurologic examination is the speech. Okay. If your patient is, or if the patient is able to speak, if your patient is conscious, so take note of the changes in ability and or quality. Now in here, we have to start monitoring for the slurring of speech. Next one is reflexes, the one that I told you earlier, the Kernig and the Brodzinski sign. Okay. Next slide, please. Then you have to conduct the full physical examination of your patient. So first, we had history taking to determine comorbidities, history of past hospitalizations, and then please include also the medications that your patient is taking, because CVA may have had its onset because of non-compliance to medication. That would be part and parcel of your history. Physical examination, you have your neurologic assessment to check for the responses of the client, the reflexes, motor, and the sensory characteristics. Okay, and then for the number 3, we have the full physical examination. I only have in here a few of it, but I know it is well written in your references. Okay, so we have to identify the signs and symptoms of TIA and generalized and focal manifestations. Later, as we go on with the lecture or with the discussion, we will be able to identify which one is generalized, which one is a focal manifestation. All right, still in full physical exam, we have to check for the strength, reflexes, the speech, vision, senses. In other words, we will not stop. We will not stop with history taking alone, with the neurologic exam alone, but we still have to have a regular physical examination and or regular monitoring of your patient. That is for us to be able to identify if there is progression of the disease process or if there is already response as to management, particularly the administration of medications. All right. So aside from that, we also have to check for the particular sounds in the blood vessel. So this is the Bluey, and then the neurovital signs and the BP, and do not forget the FAST. Okay. Face, arm, speech, and time. So we have face, check for symmetry or drooping. Okay. If one side, which side? Right or left? So remember in our anatomy and physiology, that the motor fibers crosses the midline of the brain. That when an injury occurs at the right side, it is the left side of the body that will have the manifestation and vice versa. Okay, so it's not unilateral. It crosses some motor fibers in the brain, crosses the midline, and so that's the effect. And then what else? The arms, is it decorticate, the cerebrate position, and then the speech, is it abnormal? Is there difficulty in expressing? Is there difficulty in understanding? Or if in case your patient if your patient is conscious, what is the characteristic speech? Is it slurred? And then time is of essence. No, make sure that if AS are present, then that would be the time that you have to call for help immediately. Next slide, please. All right. So these are the diagnostics which are appropriate for a client with CVA. CTS or CT scan. It can be enhanced or unenhanced. Remember that if a CT scan is enhanced, meant to say, there will be the use of a contrast medium. Please do not forget the informed consent. So enhanced or unenhanced CT scan or MRI or other procedures, just like angiography and or yes, the one that is also commonly used, the MRI. So CT scan is used to delineate the presence of thrombosis, hemorrhage, tumor, or hydrocephalus. Okay. Lumbar puncture is only indicated in clients with CVA if there is no increase intracranial pressure. Okay. Now, lumbar puncture indicates the signs of hypertension, atherosclerotic changes in the retinal arteries. Oh, okay. So remember, no or negative lumbar puncture or lumbar tap in cases of increased intracranial pressure. Another diagnostic exam is angiography. Again, a radiologic or imaging study which can be enhanced or unenhanced. So this outlines the blood vessels and the site of occlusion or rupture. EEG can also be employed to localize the damage, and then of course the different types of blood examinations, just like your clotting time, and then CBC or complete blood count with differential count also, because we have to determine evolving infection. BUN, blood urine nitrogen, fasted blood glucose, this is to rule out other pathology and progression of stroke. Next slide, please. Okay, so let's try to have the management now. Now for ischemic CVA, management during the acute phase, no? Oxygen therapy to ensure adequate oxygenation to the brain. Okay. Clot busting drugs must be administered within 3 hours of the onset of symptoms, because we just cannot allow further thrombosis or embolus to form that may further occlude the blood vessels. Blood thinners or medications that contains or that has a blood thinning property should also be administered as ordered. And then we also have the carotid artery surgery indicated to correct atherosclerotic stenosis. Okay, so in other words, the management that is designed for ischemic CVA is to reduce further decrease in oxygen supply. It is also aimed to increase the perfusion, as we will be giving medications that would eventually destroy or eventually dissolve the blood clots or the thrombosis in the blood vessels. The thrombus or the embolus may not only lodge in the blood vessel supplying the brain, but it can also be at the pulmonary arteries or pulmonary blood vessels. Henceforth, your patient may have pulmonary embolus, okay, or pulmonary thrombosis that could cause an a sudden death on the part of the patient. All right. So in this management per se, it already tells us about our responsibilities. I'd say, for example, if we are giving medications which are clot busting or having a blood thinning effect, what diagnostic examinations are we going to demand? Okay, so what diagnostic exams should be present before the administration of this medication? So most likely, we will ask for the clotting time, the bleeding time, we have the prothrombin time, the partial thromboplastin time, and so on and so forth, as we will be giving other medications. And also, make sure that your patient doesn't have history of ulcer formation or other blood-related disorders. Okay, so in other words, will have still to conduct a thorough history taking before giving these medications. So it's not that though these medications has been written at the doctor's order sheet for us to be administered by us as nurses, we still have to have the other supporting papers or documents that would really vouch us to administer the medication. Please check. It is always our basic right to check what is the order of the doctor and then question an order which we think which we think not appropriate, or it is more of a patient or less of a patient, and so on and so forth. All right. Next slide, please. For hemorrhagic CVA, in our etiologic factors earlier, we said that hemorrhagic CVA is brought about by rupture of the blood vessel. So therefore, our management would be geared towards, again, the prevention of the severe focal or generalized manifestations associated with hemorrhagic CVA. All right. So again, because of decreased blood supply, or there was occlusion or decreased tissue perfusion to the brain tissue, then we have to have the oxygen therapy. Okay. Pain medications for headache as ordered, control and management of underlying causal conditions, okay, and then surgery to remove the clots and also to ligate or to say to put an occlusion, that is to ligate or to suture a ruptured blood vessel, at the same time to remove also the clotted blood that will it will really occlude or prevent adequate tissue perfusion. And the presence of this blood in the brain tissue can predispose the client to secondary infection. So your patient needs to have, again, a thorough neurologic assessment plus the imaging studies that would guide or that would facilitate the attending physician in arriving at a concrete diagnosis. Okay, another one is physical, occupational, and speech therapy for residual condition. I think this will be discussed later by our second speaker. Next slide, please. All right. So these are the medications which we administer in the clinical area. I think we may be the same in some antihypertensive. We also have osmotic diuretics. We have anti-hyperlipidemic medication. We have carvedilol, or we also have the clopidogrel for antiplatelet formation, aspirin as well, and then we have enalapril, ceticolin, is brain enhancer, nimodipine, retardipine for the regulation of nimodipine is antihypertensive, retardipine for the regulation of the heart rate. In some cases, there will be a severe affectation that the vital centers or the pneumotoxic centers in the brain will also be affected by the rupture or the hemorrhagic CVA. And then we have in here meropenem, piperacillin, tazobactam, cefuroxime, when a secondary or an evolving infection is noted. And then we have lactulose. This is a stool softener in case the patient is, whether the patient is conscious or unconscious, we really have to administer this one. If the stool is some kind of a constipated stool or it's hard, therefore the patient will have to bear down. That is again the Valsalva maneuver that would further increase the intracranial pressure. So we have to do this one. But make sure that we monitor the client closely when we administer this medication or anti-constipation or laxative. So make sure that we always have the electrolyte studies in the patient's chart. Next chart. Next slide, please.
Professor Gijusa.
Okay. So we have now the two major categories of CVA, the ischemic, okay, in which your patient could have numbness or weakness, change of LOC, motor speech difficulties, severe headache. Now, this type of CVA can be ruled out or can be determined, okay, accurately through CTS, MRI, or angiography. Next slide, please.
Professor,
Hello.
I'm afraid we have 10 minutes left.
All right. Okay. These are some causes of ischemic CVA. Okay. So these are conditions which could either be present, congenital abnormalities, or can be acquired. Okay. Next slide, please. So remember that most CVA is ischemic in nature. Next slide. For hemorrhagic stroke, we have these manifestations, and again, this will be determined or we will arrive. It's a complete diagnosis through this imaging studies. Next slide, please. Okay, so intracranial hemorrhage within the brain, subarachnoid space between the brain and the thin tissue of the that cover the brain. Next slide, please. Okay, so these are some causes of CVA. You have that in your book, I'm pretty sure of that. And this comprises about 13% of most CVAs. Next slide. Okay, so this is the stroke continuum. It starts with TIA, which lasts less than 20 seconds, but no more than 24 hours. And these are the manifestations. Next slide. Then number 2 in the continuum is reversible ischemic neurologic disability or deficits. It resembles that of TIA, but the neurologic symptoms last longer, up to 2 days. Now we also have the stroke in evolution. Now it begins as a relatively small neurologic deficits that increases over a period of hours to days. And then we have the completed stroke, that your patient will already have deficits in terms of neurologic functions as well as the other systems of the body. Next slide. Okay, so these are the onset of CVA. These are the manifestations. First, your patient will have unconsciousness with stertorous breathing, you know this one, elevated BP and RR. There will always be facial paralysis. The hands and eyes are moved towards the injured side of the brain. Swallowing reflex may be absent, as well as the deep gentle reflex. Next slide. And these are the first aid of CVA. Now, this can be performed whether the patient is in the hospital or in the community. Maintain an open airway and provide adequate ventilation. If the patient is not breathing, stop CPR. Position on the affected side with the pulse of breathing or absent. However, if a mechanical airway, say for example, an tracheal tube is in place, do not position the client on the affected side because the pressure can cause decreased blood perfusion or blood supply, and therefore it can also result to stiffness of the muscles. Loosen the constricted clothing and remove potentially injurious. This is for the safety of the patient. Elevate the head slightly to prevent increase in intracranial pressure. Note the extent of paralysis, the skin color, sensory loss, and convulsion. Again, the vital signs and the level of consciousness, and then provide emotional support. But do not provide false reassurances. We are uncertain of the condition of the client. Okay, no or negative false reassurances. Next slide, please. These are the different nursing diagnoses. I think these are found in your book. And I have just formulated this based on the presentation that I have. Next slide, please. All right, so planning and implementation during the acute phase, we have during the first 24 to 72 hours. Maintain an open airway and provide adequate ventilation. Again, your oxygen inhalation at 4 to 6. Now, class, this is different from when your patient do have COPD. It should be lower than this, 1 to 2 liters only. But this time, we want to adequately oxygenate the brain tissue. Therefore, it should be at a higher level. So 4 to 6 LPM or liters per minute via nasal cannula. Suction secretions PRN. Please do this without creating the gag reflex, or the client will have to have forceful swallowing because that can increase intracranial pressure. Turn the patient to the lateral side every 2 hours. But for the affected side, it will only be for 20 minutes, not more than that. Again, remember the pressure and the stiffness of the muscles as well as the parts associated, the parts that are on the affected side. Cough and deep breathe if your patient is conscious every 2 hours while in bed. Next slide, please. Administer medications as ordered. So you have your vasodilator, make sure to compute adequately, know the options, and also the side effects and the adverse effects. Say, for example, your salicylates, your narcotic analgesic, we also have anticoagulants. Make sure that when you administer heparin or the warfarin, you know your responsibilities. Again, the diagnostic examination that we need to have when we administer these types of medication, because in some hospitals, these are still used, is to have on hand the partial thromboplastin time as well as the PT or the prothrombin time. Now, along with it also, of course, is the clotting time and bleeding time of your patient. Right. So we have the heparin, which should be administered it subcutaneously, negative or no massage class, no massage, and then use only the appropriate needle. Take note for the contraindications of heparin, like if your patient is taking salicylates or medications with blood thinning properties, do not administer heparin because all the more that your patient will have bleeding. Steroids, penicillin, phenytoin should also be are highly contraindicated to clients who will receive heparin. Okay, now if a warfarin, sodium, or acomodine is ordered, then we have to check also for the prothrombin time of the patient. Of course, we know the action of the warfarin and acomodine. It reduces the action of vitamin K to produce more prothrombin and thrombin. Next one is we have, all right, so on the hypertensive stool samples. Next slide, please. Okay, complete bed rest positioning. No to supine position because the tongue may obstruct the airway, thus causing aspiration or difficulty in breathing. So you have to check that one. And then feeding should be through NGT or nasogastric tube. Make sure that you let your patient assume the correct position, and then checking also for the patency of the NGT prior to administration of the feeding. IV fluid should be administered at a correct flow rate. Have that regulated regularly, and then what else? FBC if indicated. Now remember that the the Foley-Bag catheter should be changed every 72 hours. This will prevent the ascending infection for UTI and therefore subrenal problems later on. Okay. Perform neurologic check hourly, encourage verbalization of feelings, and then provide psychological support or reassurances. As mentioned earlier, no to false reassurances. Next slide, please. All right, nursing interventions, acute phase, maintain patent airway oxygenation, proper positioning, lateral to prevent aspiration. Again, no supine position. Therapeutic temporal alignment, body alignment, and turn to sides every 2 hours. This is to prevent contractures. Footboard or high-top sneakers to prevent foot drop and contractions. That is, of course, when the patient is on bed. We can make use of flotations or egg crate mattress or sheepskin to prevent pressure injury. So we're talking about decubitus ulcers or bed ulcers. And then, of course, the vital signs, the BP and your vital signs. Check for the presence or absence of voluntary or involuntary movement. Okay, next slide, please. Rehabilitative phase, prevent deformities, retrain affected extremities, encourage early ambulation, help the patient gain much independence as possible. So for example, performance of ADL, provide bowel and bladder retraining. Remember that your patient has been on FBC and then immobilization because he or she was always in bed. Then we have to have retraining. Speech therapy and then adequate nutrition. Next slide, please. Administer meds as ordered. Again, the complications increasing ICP, particularly for hemorrhagic CVA. And then monitoring for intake and output, GIT function, prevent constipation. Remember, no constipation because that can increase intracranial pressure when there will be Valsalva maneuver. Fluid electrolytes, balances. Make sure that you have again on hand your fluid electrolyte studies. Skincare to prevent pressure injury. And if aphasic, speak slowly, repeat the keywords, and use simple commands with gestures or picture. Next slide, please. All right, on the third day, this is where rehabilitation will start. So we have to assess for hemiplegia. So this one, next slide, please. So our goal in here is to prevent deformities. Next slide. Okay, so these are the specific nursing care to prevent deformities secondary to hemiplegia. Okay, next slide. Next slide. Okay, now it should be that we have to make or let the patient and the family learn to accept the condition. It is a long-term condition. All right, dysphagia is another thing that we have to monitor, that we have to assess in the rehabilitative phase. I think this was mentioned earlier. Our concern here is the prevention of aspiration. And these are the specific nursing cares. Next slide, please. Okay, homonymous semi-anopsia is impartial or total loss of vision in one eye. Again, another complication that we want to prevent in the rehabilitative stage. So these are the specific nursing interventions. Next one. Next slide. Okay, aphasia or speech and comprehension. I'm sure this will be tackled earlier by our next speaker. There are two types of aphasia, receptive and expressive. Receptive is difficult in understanding, while, and these are your specific nursing interventions. The second type of aphasia, next slide please, is expressive, difficult in making thoughts known to others. Remember in CVA, it could either be, there is really affectation in the Broca's area as well as the Wernicke's area. These are the areas for comprehension, understanding, expression of emotions, and so on and so forth. Again, for expressive aphasia, these are our specific nursing interventions. Next slide, please. Okay. Apraxia is disturbance in coordination. So we have to guide through intended movement, keep repeating the movement. And the last one, I think this is the last slide. Hello. All right, take note that during the acute phase, you should still perform all the assessments and interventions. So we'll never stop, as I've said. If the patient is unconscious, maintain the airway, conduct neural assessment to ensure that the patient's brain is adequately oxygenated, and during the rehabilitation phase, perform detailed neural examination and record the patient's progress accurately at regular intervals. This is again for us to determine the client's response to therapy or to medication, or if there is progression of the disorder from the acute phase to being worse in terms of severity. Next slide, please. All right, so these are, if there are causes, if there are risk factors, then we will have to have the prevention. It is always that when we identify the causes, we know how to prevent also these causes so as not to develop a disease process. Maintain normal blood pressure, limit saturated fat and cholesterol intake. So we'll only have to eat fish. Refrain more or often. Refrain from smoking and drinking alcohol. Drink alcohol in moderation, but we are allowed. Now, adults particularly are allowed to have their at bedtime dose of about 30 cc of the wine, because it is again considered as a substance that would dissolve cholesterol. So 30 cc, not 1 glass full, but 30 cc. Another one is to control diabetes, exercise and medication, maintain a healthy weight. Okay, it should be at par with your age and your height. And of course, get a regular exercise and eat a diet rich in vegetables and fruits. Last slide, please. Okay, so thank you so much. Have a nice day, everyone.
Thank you, Professor Jejusa. That was a really comprehensive lecture on managing patients with stroke. So yeah, for all participants, if you have questions to Professor Jejusa, you can ask directly by raising your hand. Do we have a participant who will ask question directly? Okay, we don't have yet. While we're waiting, Professor, it's interesting that before you said that the physiotherapy of patient with stroke can be started in 3 days after the event. So my question is that apply for all patients with stroke or just for, I mean, we have to assess first the condition of the stroke.
Yes, Ma'am Ira. So the acute phase of the CVA, as mentioned earlier, may not be true to all patients. There are patients who respond slowly, others would respond immediately. So we have to, or start response to the disorder. Now we have to go back. What are the risk factors? Why is this patient having the severe form of the acute phase of CVA? So again, our history taking as well as physical examination will really contribute much to the onset, to determining the onset of CVA.
Okay. Yeah. So it's the better the sooner, but we have to start. We have to wait until the 3rd day to start the physiotherapy. Okay, thank you. We have one question in chat room from Ibu Anggun. This is also one of lecturer in Poltekkes Kemenkes Malang. Hello, Professor Jejusa. Thank you for your awesome presentation. I would like to ask you, what will happen if patients arrive late to the hospital more than 3 hours from the onset? Should we should clot busting drug still be administered to the patient after 3 hours?
Should be
clot busting drug. Do you mean fibrinolytic, something like that, Miss Anggun?
Yes, ma'am. That is immediately ordered at the patient's chart. So we administer that at the emergency room while the patient is still there. Now, the one that we use is the fundaparinox, and that is administered through IVTT this time. Now, if our patient is at the acute stage of CVA in PO, so meaning to say that we will not give anything because we have not conducted yet our thorough physical examination for fear of aspiration. So everything has to be administered via the intravenous route. There are medications, blood busting, which are administered through intravenous route.
But maybe we should determine first what kind of CVA that the patient has.
Yes, ma'am.
Yes, ma'am. Okay. Do we have participants who want to ask directly to Professor Jejusa? Maybe Ika? Ika, maybe you can unmute and ask directly to Professor Jejusa. Ika Amalia.
Hello.
Hello, Ika Amalia.
Hello, Mom.
I think Mom Ira, it's written at the chat box.
Oh,
is
yeah.
This the one, Ma'am Ika?
Wait for a second. Yes, this is. Yeah. This is from Ika. I want to ask Mr. Jesuka as the first speaker. Ma'am, if there is a patient CVA who is unconscious and the family refused to be given nursing action in the form of installation of feeding utensil, what should the nurse do?
All right. First, the patient is unconscious.
The patient is unconscious, and we have to put NGT, something like that, but the patient...
Sorry, Mom Ira.
Yeah?
All right. Yeah, so we are talking, Ms. Ika, you're talking about the insertion of the NGT as a route for the administration of feeding.
We talk about what the nurse, as a nurse, we have to do if the patient needs NGT tube but the family refuse. How we educate that this is important or this is essential for the patients.
Yes, yes,
Yeah.
yes. Because we have to maintain, number one problem or another problem also in clients with CVA is inadequate nutrition.
Yeah.
Right? Inadequate nutrition. All right. Now, this is a type of problem which we have to deal with the family. There must have to have a thorough explanation or discussion to their level of understanding, and we have to point out the significance of having this this alternative route for feeding as it is very essential. I think we can start with the identifying the essential nutrients also essential for the patient's recovery of the disease process. But because of, not being able to have a consent on a particular procedure that will be performed on a client, for me, is just an information that is very lacking. So meaning to say that we really have to assert ourselves because we know more than them in terms of, patient's recovery, patient's, our goal in maximizing the remaining potential of the patient, because we just do not want patients to go more into what is known as the worst scenario. So it should be that we need to have a proper communication. That is why I told earlier the group that the nursing care plan should be discussed well, not just with the patient, but for the entire family, for them to understand what are the procedures that will be performed. This is a life-threatening condition, and therefore it will affect most systems of the body. Therefore, you as a nurse, we as nurses should be assertive in terms of implementing our nursing interventions. Our goal anyway is to prevent further damage to the patient. So we really have to assert in this case.
Yes. Yeah. Thank you. So we have to try to educate more, and then we have to ask more information, make sure that the patient and the family understand the importance of this procedure. Okay, thank you.
Yes, Mamera, that's very correct.
Maybe we have another question from Sabrina. Sabrina has raised her hand. Sabrina, you can ask directly to Professor Jejusa. Yeah.
Okay, thank you, Miss Ira. So I want to ask to Miss Jesusa, thank you before. And if we talk about the types of cerebrovascular that has been taught in your slide before, I want to ask you, what is the first step can we do for handling of each type of cerebrovascular disease with pre-hospital condition?
Or you can just type your.
Professor, you still unmute? You still mute? Yes.
Come again, Ms. Sabrina. I wasn't able to catch some of the words you expressed. What was the question?
Sabrina, can you repeat the questions?
Okay. If we talk about the types of cerebrovascular that has been told in your slide before, I want to ask you, what is the first step can we do of handling for each type of cerebrovascular disease with pre-hospital conditions?
I see. Okay. So the types of CVD that we mentioned earlier, like the CVA, the TIA, and cerebral aneurysm. For CVA, that needs really an immediate attention. Now, it was given in one of the slides, the manifestations of a client with a sudden onset of CVA. But this is not true to all patients, as I've said. This is not true to all individuals that they will have the same manifestation at the time. There may also be individuals who may have a subtle manifestation of the disease process. Okay, first, what are we going to do? Now, in case it was given earlier that if your patient is really, there are obvious manifestations of CVA, like facial asymmetry, like stertorous breathing, like negative consciousness, and so on and so forth, we need to fast. Meaning, check immediately the face, the arm, and also the time that your patient should be transported to the hospital. So act immediately for CVA. But if your patient do have TIA, first we have to observe. Remember in TIA that it is a warning sign of an impending CVA. So meaning we have to at first observe the client. The first classification, if I'm going to repeat, is CVA stroke, TIA, and cerebral aneurysm. TIA is considered, well, in CVA, we need to have an immediate response. For TIA, in as much as it is a warning sign about impending CVA, then a thorough or close monitoring of our patient is very essential. So what are we going to do? Start again with the history taking, physical examination, neurologic assessment, and then some focal or general manifestation should be noted and be reported. Again, the description of TIA is a warning sign that soon your patient is going to have a CVA. So close monitoring is very essential. Whereas for cerebral aneurysm, as much as it is associated with congenital softening of the blood vessel, it needs also an immediate attention. Why? Because the affectation may be at the anterior portion of the another portion of the circle of Willis. When we say anterior portion, that is where the junction of the blood vessels would join. So meaning to say, it is also quite fatal if the affectation is found at the anterior portion of the circle of Willis. All right. So these are the things that we have to do. So meaning to say that we have to be keen observant, and also we should never stop talking with the patient and the family, all with regards to what is going on in our client. Take note always of the history of your patient and the comorbidities that your patient has had.
Yeah, that was a clear explanation about how to handle first patient with different kind of cerebrovascular accidents. Maybe we have the last question. This is from one of our students. It's already clear, but maybe you can elaborate more. I mean, explain more. Is transient ischemic attack the same as ischemic stroke? And what are the difference between the two disorders?
Okay, it is the same. Transient ischemic attack is, of course, the same. 1 and 2 person have transient ischemic attack. The causative factor for that is always ischemia. And what is ischemia? What brings about ischemia in the brain tissue? Of course, these are the occlusions, these are the narrowing of the blood vessels, but it is never brought about by a rupture of a blood vessel. So meaning to say, it is gradual in terms of onset, because atherosclerosis doesn't happen immediately. It is gradual, and therefore TIA will also develop gradually. Manifestations will be seen or will be noted with the client or when the person is already in its mid, say 30s or 40s, something like that, or 50s.
Yeah. Thank you. So, Ms. Rahmawati, it is the same. The difference maybe the TII is the first event to be ischemic stroke. I'm afraid that our time Hasab. Okay. Thank you again for sharing with us today. We are really delightful to have you here.
You're always welcome. Welcome, Ma'am Ira. Welcome,
Thank
Dr.
you.
Kisa.
Yeah,
Hello.
Dr. Kisa.
Yes. And
Dr. Kisa.
administration of Health Polytechnic
Thank you.
of Malang. Thank you so much.
Yes. Yeah. Thank you, Prof. Yeah. Maybe. Yeah. So that was the first session, the first lecture with Professor Jesusa. The committee, do we start the second session to right now? Okay.
Yes, Miss. We can move to the next session.
Okay. So for the second session of this seminar, we have an expert from Malaysia, Ms. Sharmila. She is a lecturer of physiotherapy in University Technology of Malaysia. Hello, Ms. Sharmila. Oh yeah, are you with us?
Hi, Miss Ira. A very good afternoon. I hope I am audible. Am I clear, loud and clear?
Yeah, you are loud and clear. Do I pronounce your name correctly, Sharmila?
Yes, Miss Ira. You can just call me Sharmila, no worries. Okay.
Thank you, Mr. Mila. Anyway, I will call you Mr. Mila. Okay.
All right.
Before we start your lecture, allow me to read your profile. So next, Ms. Sharmila is a lecturer, yeah, in physiotherapy of National University Technology of Malaysia, and her educational background. She graduated from Master of Health Science from National University of Malaysia in 2016. And then she did her Bachelor's Science honor degree in Physiotherapy UK from Northumbria University in collaboration with Mahsha with first class honor graduation, and then was the valedictorian of the ceremony. Yeah, next. And then she did about 1,000 hours of clinical practice as undergraduate students in various hospital in Malaysia. And then also she was a clinical instructor at Hospital Ampang. Next. Yeah. As I mentioned before, she is now lecturer at Center of Physiotherapy Studies, Faculty of Health Science at University Technology Malaysia. And before that, she was also a physiotherapy lecturer in Inti International University. And then also before, from 2013 until 2020, was a lecturer in Mahsa University. Next. Yeah. She has conducted many research and achieved grants and also publication, mainly in managing patients with stroke during rehabilitation, rehabilitation and for patients with low back pain. Next. Yes, and she is a multilingual person. She speaks English, Bahasa Melayu, Tamil, and Mandarin. Yes. So Ms. Sharmila, we have about 1 hour for the lecture, and then after that, about 45 minutes for the discussion. Time is yours, Ms. Sharmila.
Okay, great. Very good afternoon once again to Ms. Ira, everyone who has successfully organized this international seminar. Okay, so as of my sharing today, I would be sharing mainly on physiotherapy program for patients with cerebrovascular accident, CVA in community setting. So for those who are still wondering what is physiotherapy, so physiotherapy, we rehabilitate mostly on the physical aspect, but not forgetting the biopsychosocial aspect as well, which means the biological aspect. So we have to have a little bit on the medical understanding and also the psychological understanding as well as the social understanding, right? So physiotherapy mainly to habilitate and rehabilitate. As of today's topic, we are talking about in community setting. So earlier, Prof. Jesusa, she has talked about what happens in the hospital setting. So today, I'm here to mainly talk about what happens when the patient goes out, goes to the real life, real living, and how we can actually habilitate or rehabilitate them in the point of view of a physiotherapist. Okay, could you please go to the next slide? Okay, so this is my outline. So number one, I'll be talking a little bit about the introduction to CVA. Not to worry, not too much of facts. It will be mainly associated with rehabilitation and the consequences following CVA, which means as a physio, what are the consequences that would bother me as a therapist and what I should address. Number three is the physiotherapy program for patients with CVA in community setting. And lastly, I would open the floor for question and answer. Yeah. Thank you. The next one, please. Okay. So a little bit about why stroke or CVA is very common among neurological physiotherapists. We have to understand what is the statistic and what are we looking at when we think about, okay, CVA, what is stroke? Second leading cause of death. And it's not a joke, it's a huge thing. Yeah, it's a second leading cause of death and third leading cause of death and disability combined. What concerns me as a therapist here is the second word, the death and disability combined. What is the meaning? Apakah maksud death and disability combined? We have to understand there is a term called DALYs, D-A-L-Y, disability adjusted life years. This is very concerning in the field of rehabilitation because we are not looking at a life or death alone. We are looking at, okay, if my patient is out of the danger, what is the productive life that the patient is having? What kind of life that they can return to? And that is actually a major hindrance following a stroke. And that is why it is a third leading cause of death and disability combined. So to put it in a nutshell, how many of healthy life has my patients lost because of stroke? And that is concerning because of the stroke itself. And looking at the statistic, there are over 12.2 million new strokes every year. And this is not a small figure, and this is concerning us as well. 47% of stroke happens in men and 53% happens in women. Let us reflect a little bit about what Prof. Jesus has talked about earlier. The consumption of the oral contraceptive itself can contribute to the risk of stroke. Of course, besides other modifiable factors like obesity and etc. But is that all? We are looking at the prevalence of breastfeeding. A recent paper has mentioned that the prevalence of breastfeeding, as higher it goes, it reduces the risk of stroke by 23%. So these are the factors, what I called as gender specific or female specific risk factor that could probably explain why the number is slightly higher in women compared to men. Yeah. And lastly, women experience intracranial aneurysm and subarachnoid hemorrhage more than men, while men generally experience a higher rate of hemorrhagic stroke. Okay, the next one, please. Okay, thank you. So 6.5 million people die from stroke annually. So let us take a little bit about the figure. So earlier we talked about close to 12 million of stroke and at least 6.5 people die annually. So we are looking at a 50% to 60% solid stroke survivors who are experiencing disability. And ladies and gentlemen, I'm here to say that stroke, it's not like once I get it, I will never get it again. There is something called recurrent stroke if you don't take up your rehabilitation seriously, right? So that is concerning as well. And 51% of all deaths from strokes are in men, while 49% are in women. And if you look at the percentage of people suffering because of stroke. Look at the figure, the second point here, 15% of people between 15 to 49. And this age is concerning because you're here looking at young adults as well. And then the next one, we are having 57% of people under the age of 70 years. So which means to say stroke varies across the age, be it young, be it old. And of course, as you get older, your chances of recovery is being impaired by the age itself, because your aging, your what do you call this? Your aging process is going to slow down it further. So there are over 7.6 million new ischemia stroke, over 3.4 million new intracerebral hemorrhage, and 1.2 million new subarachnoid hemorrhage. So you can see here, ischemic stroke is at one corner is 7.6, and you have hemorrhagic stroke. We are talking about rupture, we are talking about bleeding, and this figure is also concerning because when you talk about ischemia, you're thinking about, okay, what are the modifiable factors? Are we talking about your cholesterol, hyperlipidemia? And when you talk about hemorrhage, are you thinking about hypertension? So these are factors which you can modify. So as a therapist, that is why I mentioned earlier, I'm not only looking at rehabilitation, my patient, I am also looking at rehabilitation. So my concern as a therapist, bila saya fikir as a physiotherapist, it is not just, okay, I have to get my patient better. That is number one. Of course, that's a priority. But number two is, I must make sure my patient doesn't get a recurrent stroke. That is, that is my role as well, because recurrent stroke is common. If you are not going to stop smoking, if you're not going to modify your BMI, if you're not going to modify your diet, and this is going to happen. So rehabilitation, ladies and gentlemen, it's not just up to the physiotherapist alone. It is a multidisciplinary approach where we are looking at medical team, we are looking at nursing team, we are even looking at the PT, OT, speech, psychologist, dietitian, and etc. We work as a team. But unfortunately, I can't cover everything today. So we are just going to look at the physiotherapy aspect of it, right? Thank you. The next one, please. Okay. So when we, I'm not sure how many of you are familiar with the term ICF, International Classification of Functioning. When we are looking at an impairment, we are not just looking at, okay, can my patient walk? Because the topic of today is community. So my concern is, okay, my patient, for example, let's take a simple scenario here. My patient is having stroke. So let's say there is a set of hypertonicity, which means the tone of the muscles, especially of the lower limb, which means the legs, are increased. So of course, when I know that the body structure, which is the leg, is being impaired, the function is impaired because of the muscle has gone for hypertonicity. Maksudnya, the muscle's tone is now a little bit spasticity. Okay, it's a little bit harder for it to move. So now I want you to think, what could be the next problem in terms of activity? As a physio, I look at the body structure. Okay, legs having high tone. That's it. But I can't stop there. I have to think one step further and ask myself, because of this problem, what are the problems my patient is going to face in the activity? So number one, patient's mobility or walking is going to be affected. Okay, so that is only the second problem. The third problem is, okay, so what happens if my patient's walking is affected? For example, my patient has to cross the road. Traffic light, it doesn't wait for you. Okay, it has a set of time. So if my patient, it's not just important, bukan penting sahaja, okay, if my patient can walk or not. My patient, can he walk as fast as others to cross the road within that particular seconds that the traffic light is operating? So you see how we are thinking when we are rehabilitating our patient into the community. It is not just about, okay, I have to reduce the tone. No, I don't stop there. I have to think, okay, if I reduce the tone, can my patient walk? Number two. Number three, if my patient can walk, can my patient cross the road within the stipulated time period? You understand? So there's a lot of things that we have to think, and this is where ICF comes into play. I'll just highlight the ICF in a bit. But this is a whole set of impairments that we are looking at: altered consciousness, attention, alertness. Of course, we physios, we do not have a direct role, just like what Prof. Jesus has mentioned earlier, in terms of the medications and etc. But we have to understand in acute stroke, the patient's consciousness is important because we will be doing our own set of assessment. Okay, in here we are looking at the cognition because we need the information from the patient of the awareness where we are today, what time of the day is, because or else the rehabilitation is just going to be a waste of time because patient need to understand what we are doing for them. Then we have reduced energy or motivation, okay? Dysphagia, swallowing difficulties, right? Dysphonia, okay, in terms of the voice generation, it's very hard, it's not very smooth. Then we're talking about dysarthria. Dysarthria here we are referring to, for example, if my patient is having the muscular disturbances of the muscles which is affecting the speech. Dysphasia is a language disorder, we call it. The comprehension, my patient is unable to complete a sentence. Of course, this is the role of a speech therapist. But for me, as a physio, or those who are in the rehabilitation, we have to understand my patient should be able to understand the task that is given. So, but in neurology, in stroke specifically, once a week, physiotherapy is not going to be helpful. You need everyday physiotherapy. Unfortunately, we have cost. We have the manpower issues. We are not able to provide physiotherapy every day for our patient. So what we do, we give them patient education. We give caregivers caregiver education. So this is important. So for that, we need to make sure patient is able to comprehend. If patient is having dysphasia, then there's going to be a comprehension issues difficulty. There is going to be expressive difficulty and so on. Then you have reduced muscle power. We have reduced muscle tone. Sometimes it's not reduced. It can even go for hypertonicity, but not in acute. Hypertonicity doesn't set in overnight. Yeah. Sometimes when we see in the movies where, patients walk with the hands a little bit tight, that doesn't happen overnight, ladies and gentlemen. It takes time. Okay, and that is why you see the word reduced muscle power or muscle tone. Hypotonicity takes place in the beginning. Then you have altered sensation, proprioception. When I ask my patient to close the eyes and I bend my patient's elbow, I ask my patient, okay, what am I doing with your elbow? Is it bent or is it straightened? And they goes like, oh, I can't tell you. And that is a problem with proprioception. Then we have reduced coordination, change in temperament, change in their personality, executive dysfunction. They are not able to problem solve. I'll show you how we deal with this in terms of our rehabilitation. The interesting part is yet to come. So please bear with me, ladies and gentlemen, right? Then we have perceptual changes, loss of visual acuity, reduced joint stability, reduced mobility, balance impairment, and lastly, the altered gait pattern, which I'll be talking in detail about, right? Could you please move to the brief ICF concepts of stroke? The bottom one. Okay. Apologies because my slides were in PDF because I used Canva. So I think that is why we're having difficulty in presenting because I think it is changed into Word format. So apologies for that from my side, right? Okay, so when we talk about stroke, remember I talked to you about body function, body structure. How do we rehabilitate our patient? Number one, of course, we look at the body function, which body structure is affected. If the brain is affected, obviously, in the case of CVA, I am expecting there could be some issues with consciousness. There could be some issues with the memory. However, we have to understand our cerebral cortex does the sensory processing. It does the motor execution. So I am also worried about my muscle power functions. Because of the descending pathway, you are thinking about your corticospinal tract, which is being affected in upper motor neuron lesions like stroke. That's I'm aware. But what is more concerning is, I want you to look at the next one, activities and participation. Walking is affected. speaking is affected, toileting, eating, washing, dressing, and even communicating is affected following a stroke. And that is the next part, which is activities. Participation is something that is less spoken about. Because when we talk about stroke, can you walk? Can you feed yourself? No, it should not stop there. We have to think, like what I've mentioned earlier. If you think you can feed yourself, how well can you feed yourself? Are you confident in going to a restaurant and hold the fork and spoon and eat by yourself? That is participation. And that's what we strive to achieve in our last part, which is achieving our patient to get back to community, the community reintegration. Yeah? When you talk about participations, for example, we talk about walking, all right? So earlier we talked about how fast can the patient cross the road, right? That is participation in community. But is that all which is sufficient? We are looking at how long my patients can walk. Can they walk 250 meters without pausing, without stopping? So that is something which we are looking at in achieving. It is not just, okay, my patient can lift up the leg and my patients can walk. Can my patient drive the car? Which means now we are looking at the coordination of the upper limb. We are looking at the coordination of the lower limb, because you need to press your oil, you need to press your clutch, you need to turn your steering. So you see, that is, ladies and gentlemen, the participation aspect. Earlier we had a question, right, for the nursing part. What happens if the caregiver refuses a certain treatment to the patient and when the patient is unconscious? Like it or not, this happens in our field as well, the rehabilitation field. Because maybe the perception that we create on physiotherapy is we are strict and we like to push our patients harder. And if you see any hospitals, the physiotherapists are quite loud, aren't they? They like to give that to the patient, keep going, boleh, semangat, give that encouragement. I think that's the nature of us, the therapists. Even now I'm speaking with you of full enthusiasm. And that's just us, the nature of us, right? So what happens is that when we go into the environmental factors, boleh naik sikit, I want to see the what do you call it, the environmental factors just a little bit. I think I'm not sure if it is hidden at the bottom. So we have the immediate family, health professional, health services, systems and policies. Look at the environmental factor. For a rehabilitation, not just rehabilitation, for a management to be successful dalam community, we need the involvement of the family members. It's very important. You cannot work by yourself, especially in a condition like stroke, because stroke doesn't heal overnight. It takes a long time. We have acute stage, we have subacute stage, we have even the chronic stage. So sometimes the family members can be the facilitator. Mereka bantu dalam the rehabilitation, they be helpful. Sometimes they become the barrier, penghalang. They don't let you do your work as much as you want, because like I mentioned earlier, in community, dia become like in the hospital. You cannot see them every day. So you rely on the caregiver to make sure that the task is done, the task is conducted. If you give them a set of exercise, you hope that they do it until they come for the next visit, right? So this environmental factors plays a greater role. Another one I would like to emphasize is the health professional. Sometimes they can be a facilitator and sometimes they can be a barrier. If you do not have a referral, for example, let me ask you, ladies and gentlemen, when we go into the ward, when we see stroke patients, right? In the acute stage, the muscles goes for hypotonicity, no muscles, so mishandling causes subluxation of the shoulder, which means the ball of your humerus is not sitting exactly at where it's supposed to be. So there is a slight reduction. There's a slight gap in that. What happens if we do not refer them to an occupational therapist immediately? If we are not aware of the role of that occupational therapist and what they do in overcoming this subluxation in terms of, it could be a bandaging or a splint or even an arm support to reduce the event. And that is going to worsen the condition. I can be giving him a lot of exercises. Okay, lift up your hand and etc. But if I am not fixing the ball into the socket for my activity, what is going to happen? My rehabilitation will have compensation mechanism, compensation movement. So this is why, ladies and gentlemen, I said we work as a team. Medical doctors, nurses, PTs, OTs, speech therapists, and whole set of allied health. We work as a team, yeah? So could you please just go a little bit up? Thank you. Scroll up a little bit, please. Okay, could you just make it smaller so that it fits into the, you can just reduce the size of it. I believe it is at 60%, right? Just reduce the size of it so it fit into the, I can share it if it's too much of work.
Dikurangin jadi 50 bisa.
Yeah.
Biar kelihatan. Biar kelihatan
50.
semua.
Yeah.
50 mungkin 50 ininya size-nya. Maksudnya biar semuanya kelihatan di ini.
Yeah.
Is it enough? Miss
okay, this is perfect. Perfect. This is good. Yeah. Okay. Okay. Contoh, I want to say bila I see a patient with katakan ya, memang stroke. When he comes to me with one of the concern, I want to walk. I mean, we get this quite often, right? Walking is probably one of the most underappreciated movement until you cannot walk because everything needs movement. And the second one is your upper limb activity. For example, a simple task like getting a glass of water is underappreciated until you can't do it. So this is what we get. Can I walk after my stroke? So I want you to look at what you can see in front here. For me to make my patient walk, see how many things I need to think as a therapist. Number one, is my patient having enough muscle strength? Look under body functions and structures, under muscle strength. Does he have any voluntary movement? Maksudnya boleh my patient bend the knees. Can he do it without my help? Cardiovascular fitness, because when we walk, sometimes we become breathless. SOB sets in, shortness of breath. That is not because of the muscle. That is because my cardiovascular, my VO2 max is impaired because of my stroke. And then we are looking at the spasticity, which means the hypertonicity. My muscle now has become hypertone. It's difficult for me to make it into lengthen it. And then sensation. Maksudnya bila the patient place the feet on the floor, boleh my patient tell me, okay, my feet is on the floor. Dia bisa kenal. That means whether my patient is able to tell me, okay, my feet is on the floor, now I'm lifting the feet or not. So these are my things that I have to think as a therapist before I make my patient walk. Number two, what I want as a therapist. Is it enough if he walks? Macam tadi I kata, walking speed is satu. Walking distance. Can my patient walk long enough to cover a normal movement or not? For example, the bed. If you go into the ward in the hospital, the toilet will not be very close. Some cubicle, yes, it will be closer to the toilet. But some cubicle requires my patient to walk. So at least 100 meters, can my patient walk or not? So that is, my dear, walking endurance. How long? What is the distance my patient can cover? The next one is walking speed. Walking on various terrains, because we live on earth and earth is not smooth, right? Sometimes we have to walk on smooth surface. Sometimes we have to walk on the road. Sometimes there will be a drain which requires you to cross them. So you see, walking is a simple thing, but we have to think on various aspects. The next one is participation. Domestic life. Mungkin that patient who is a stroke survivor, let's say he's a teacher, which requires a prolonged standing, which requires a bit of walking. How will his work be affected because of that? Because we are talking about getting back our patient back to community. It's not just enough for me as a therapist, okay, my patient discharge is enough. No, I have to think, okay, how he will be walking. We have to ask in our assessment, okay, when you go back to work, do you have to climb stairs or not? Which means if yes is the answer my patient is giving me, stair climbing has to be there in my therapy. If that is not in my therapy, I have failed as therapist to address his need, which means if I don't address that, his participation is going to be affected. And then we're talking about the interpersonal relationship. Maybe he is the sole breadwinner of the family. he has to go to work. That is why we have a program here in Malaysia, return to work program, which means they have to enroll themselves into this program to make themselves fit to be able to work again, because that is going to be affecting their relationship. Maybe he is a father, he's a mother, and he's the breadwinner of the family. Okay, so all these, I can go on and on about this slide alone, but I have to keep it short and sweet. So environmental factor, accessibility is one thing, ladies and gentlemen. Bila kita kata community, is his place have the community program for physiotherapy where he can enroll himself or not? That is accessibility. If have, it's good. If doesn't have, what should I do as a therapist? Safety. If my patient can walk, okay, does my patient need any assistive device? That is why we see our patients with stroke, they use the quadripod. We have to assess the suitability of giving them the quadripod to make their walking even more safe. And of course, the last but not least, the personal factor, whether the patient himself wants the changes or not. If patient doesn't have the motivation, we cannot, no matter how much you force him, it's going to be a failure. So what do? Do we give up? No, we don't. This is where our friend psychologists come into play. Health counselors come into play. That's how we have to think for rehabilitation. Yeah. Okay, the next slide, please. Okay. All right. So importance of physiotherapy program in community setting. So why we therapists, we encourage, yeah? Okay. Why we physiotherapists encourage our patients to be there out from the hospital to the community setting. Number one, reduce the length of stay in hospital. What happens if there is a longer stay in hospital? Besides cost is the exposure to the virus, exposure to the other condition. What I'm worried is the hospital acquired pneumonia that patients can themselves get. Improve patient reintegration back to community. We want my patient to be out there, to be able to work, to able to walk. Number three, improvement in quality of life. When we say quality of life, everyone talks about quality of life. How do we understand the term quality of life? What kind of life my patient is having? Is he satisfied with the life? Is he having anxiety? Is he having pain? What about his relationship with his family members? That is quality of life. Fourth is the possibility of reducing the high workload of physiotherapists in the hospital setting. Number five, accessible and frequent rehabilitation needs, because only in community setting, patients can get the frequent rehabilitation need. Sometimes in Malaysia, we go by case by case. If our patient, we find that the patient is a little bit in need of our help, we get our patient to come at least 2 times a week or 3 times a week. But that also depends on the schedule. Some patients can even have to wait for up to 2 weeks to get one appointment with us, the physiotherapist. But this is not the case as in the community setting. In the community setting, because we have various community setting which offers the physiotherapy care, and that is the advantage of physiotherapy program in community setting. Number 6 is the involvement of family caregivers. Number 7, of course, is much cost effective to do a physiotherapy, to do a rehabilitation in community setting, because it would be closer to home, it is more functional, it's more meaningful, and most importantly, it's more fun. The key principles of physiotherapy program in community setting, I think the slide is at the bottom. Can you please scroll down? Just go down a little bit. Yeah. Okay. So this is what we are going to talk about. What do we do when we are training our patient? This is a general principle. I'm sure you have heard about the principle neuroplasticity. It is rewiring the brain. We are teaching the brain new tricks, but it's the old brain. Okay, so but we are teaching them the new tricks on how to enhance their performance. Number one, use it or lose it. Day one, stroke rehab starts on the same day. As long as hemodynamically stable, patient is fit for rehab, we start it on the day one itself. Because of the principle, if you don't use it, then the neural networks are going to lose their functions. Number two, use it and improve it, which means the more you use, the better it gets. Number three, specificity. If my patient comes to me and my patient say, okay, I'm having difficulty in drinking a glass of water because I cannot grip the cup. So what I should do? I should train one by one fingers. We can wait for 6 months for the patient to be functional. What I should do is get a cup and repeat that function 100 times. That is specificity. What you want to achieve is what you're supposed to do repeatedly. And that is repetition. Intensity. Okay, I give my patient a cup. Okay, I give my patient a cup. I ask my patient to hold it. So repeated, repeated. That is repetition. But what about intensity? Number 5. What is intensity? First, I'm going to get a bigger cup because it's easy, probably, to hold it. But then the next one is I'm going to find something smaller. I'm going to probably get a bottle which is smaller in size for my patient to grip it. So you see here the intensity. I'm giving a challenge for my patient. The next one is time matters. This is what I said. Start early. Early rehabilitation always have important recovery function. The next one is salience matters. You are doing something which is meaningful for the patient, not because you think as a therapist it is important. Maybe for my patient, lower limb function is very important compared to the upper limb function. Maybe because that's what his job is. His job requires him to stand for a long time. But you as a therapist, you go, no, I think you have to do upper limb. So there goes, you're clashing the interests. You are supposed to reward the patient. So patient, when they do something, they have to be motivated. Age matters, of course. Training the younger brain is much easier. So age, if you're having stroke in an elderly age, it's a little bit difficult comparatively to a younger ones in training them. Transference. Transference means if I'm getting my patient to do an activity, make sure that activity can be easily replicated to the real world. Okay, and then interference. Okay, this is something I want all of us to be a little bit open-minded about. We cannot aim for perfection. We cannot expect our stroke patient to walk like the one without the stroke. We have to remember that there will be compensation because you cannot wait for your muscles to heal before you can actually walk. So that is why we have the circumduction gait, where we are hiking our hip and we are clearing the ground with our leg, the affected leg, because we need to walk. So compensation is normal, but we cannot normalize it for an extended period of time. We aim to rectify it, but please don't aim for perfection. All right, the next slide, please. Can we have the next slide? If it's too much of difficult, then I can just share mine.
Maybe, yeah. Maybe you can share.
Yeah, I'm
Because
just.
I think, yeah, because it is. It seems that they have a technical problem.
No worries, no worries. I'll just share mine.
Yeah, wait for a second.
Okay.
I will. Miss Samilanya bisa jadiin co-host.
Okay, I think I can see them.
Yeah. To the committee, please, to the host, Miss Camila, please make her co-host so she can share the materi.
Yeah, I'm just worried that the pictures, because there are some pictures might be overlapping because of the change of PDF to Word. Is the pictures in order? Okay, if the pictures are in order, then we can just proceed as usual. Okay, no worries. Just scroll a little bit up. So while waiting for somebody to make me the co-host, I'll just proceed with the presentation. Just a little bit up, my dear. Atas sikit, the earlier one. A little bit up, please.
Ke atas dikit, Mas.
Yeah, this is the one. Okay. Okay. So here for PT programs for patients with CVA in community setting. Okay. So this is what we actually have done for our patients back in Malaysia. So this is called as circuit class therapy. It's basically a group-based therapy. So here we give them once a week training because when we ask someone to do exercise, it's going to be a little bit difficult, right? So we started with once a week for 60 to 90 minutes. And you can see we give 1 to 2. That means one therapist to 2 patients if they are low function and one therapist to 4 patients if they are high function. Maksudnya supervision. Kalau patient is a little bit difficult to move around, we get them to work in pair and you as a therapist, you supervise them. But if they are high function, they can be in a group of 4 and we monitor them, right? So if you look at the intensity, we have a few things. We have an aerobic station, we have a strength station, we have a balance station, and we also have upper limb station. You can ask me, oh, are you telling me that we're actually doing this in that 60 to 90 minutes? Yes, we are. Because we have to remember, we cannot think about training our patients for each for 1 hour. It's not going to work. We have to think how to come up with a physiotherapy program in community setting, which is comprehensive. It covers balance, it covers aerobic strength, which means the cardiovascular fitness, the strength, even the upper limb. That means the upper arm functions and the hand functions, right? So go a little bit down. Let us look at the pictures. Gambarnya, the pictures, please. Yeah. So what we did back in our hospital, because we trained them in the hospital before they discharge, so that they can take this back to their community and do it at home. So you can see here, we start off in the station 1 as the aerobic walking. We get them to walk. We have an undisturbed space. We get them to walk for about 15 to 20 minutes. Of course, they can rest in between. We didn't start with 20 minutes. We started off with 10 minutes and we progressively asked them to increase when they find it they are able to. The next station is called sit to stand station, which means we get our patient to stand from sitting repeatedly. Because most of your activity, imagine now all of us are sitting down, right? We have to stand up. That is a very basic activity that we don't actually think about. Even when you just sit somewhere for a while, you have to stand up, right? And when you stand up, when you're tired, you have to sit down. So that is the aim of station 2. Station 3, you can see the stepper. There was a stepper, and the stepper is mainly for, we call it a step up and step down. We ask our patient to climb up and climb down. So this is supposed to train them in their stair climbing when they go back to their community, right? Go a little bit down. Let us look at station 4, please. Station 4, down, further down. Bawah lagi? Yeah. So station 4, you can see in between. Yeah, this is good. In between the stepper and the chair, there is a black box like, right? So what my patients are supposed to do, my patients are supposed to put their leg on the stepper, on the mini stepper, and they have to lift up their tummy. They have to lift up their heel. When do we do this in our real life? I want you to think about when we cannot reach for something. we try to lift up our heel. When we want to reach something which is above us, we try to lift our heels. A basic activity requires your calf strength. So for that, a station 4, we have given a heel lift. And for station 5, you can see what I've done for my patient is, there are two oval structures on the ground. You can see the green structures, betul? And then you have a couch. It's actually a tilt table, which I've modified it. And we have this round donuts like. And then you can see in the middle, there is a string of, it's not a string, it's like a tiang, a yellow kind of wall like that. So what my patient is supposed to do, they are supposed to stand on the green ones, which means 1 foot in front, another foot at the back. And they're supposed to take the donut from their left side and from their right side, and they are supposed to put it on the yellow structure in between. So I want you to think about, what am I training my patient here? I am training my patient to constrain their base of support. Kecilkan the base of support. When you narrow the base of support, you are challenging their balance. So my station 5 is supposed to help with the balance of the patient. And then when they take up their donut and when they put it in the yellow structure, they are training their hands. Upper limb activity is covered. And look at station 6, what we have done. And what we can actually do in the community is, can you see there are some blocks? And my patient is supposed to walk crossing the blocks. This is for what? When you walk in your real life, there are times when you have to cross over things. So we are training that in our community settings so that our patient will be familiar when they go to the real life. When they have to cross a drain, they are already trained in our settings. Okay, this is how you do it, right? Can we go into station 7, please? Further down. Okay, here you can see right in front of the bicycle, you can see a straight line, a red line. I couldn't capture the whole thing. In this straight line, what we are training our patient is, we are training our patient to walk 1 foot right in front, which means they're supposed to walk placing their feet on the red tape. This is supposed to help with their balance, with their coordination, and it's actually fun. This is what we do when we were a kid. Remember, you will find that small, teeny, tiny bricks, and you would try to balance yourself walking over it. And then you have station 8. Station 8 looks some kind of hypnosis happening over there. Can you see? I have actually pasted a board on the screen. What my patient is supposed to do is, my patient is supposed to use their index finger, they're supposed to straighten their hand, and they're supposed to trace the circle. Trace the tiny bit of circle, which from small, it becomes big. When they find this challenging, but actually they're working their upper hand. Because when I ask you to just straighten your hand and just be there for 5 minutes without doing anything, you'll be bored. So we are making it interesting for our patient. The next station, you can see some cups are there. You can see some towels. Yes, we do teach our patient how to use both hands to pour from one cup to another. So they have to go this way. And then how to fold the towels. It might sound a little bit childish, but ladies and gentlemen, this is called as bimanual arm training. You are coordinating the activity of both the hands together. So what am I trying to say here is that the circuit class therapy by itself has 9 stations for my patient. I give this once a week for my patient to do it in their community. Do it just for 60 minutes or so. So every station they do it for 5 minutes only. It is fun, it covers their strength, it covers their balance. You see there is some upper limb activity, and they need to do some thinking, especially station 8. When they trace, they need to keep their focus on the circle where it is going. Okay, and then just go further down, go one step, next slide please. Pergi bawah ya, another one, yes. More down. Okay, I am not going to go into these details. This one is basically, you can look up on this article. Okay, it is the article by English Healer and Lynch 2017, where they actually say that this particular therapy, circuit class therapy, is suitable for our patient to be trained in their community because it helps in their walking, it helps in their balance, it also has some improvement in terms of their upper arm functions. Yeah. Okay, go further down, all the way down, further down. I've just summarized this because of the time constraint. So just go further down, lagi satu, lagi bawah. Okay. The second kind of program, so tadi kita bincang pasal PT program where we talk about circuit class therapy, which is a group exercise. Kita buat ramai-ramai, but we have a lot of stations. So it becomes like a competition. Okay, you buat station 4, saya buat station 5, siapa cepat habis. It's going to be fun and engaging. But sometimes it doesn't work, right? Some patients are very, I would say, introvert. I'm not sure if it's the right term to use. They like to do it on their own, at home. They are more tech savvy. They want to just do it at their own comfort. I'm not sure if you have come across with this term. It's called virtual reality. It's like a video game. It's not like a video game. It is a video game, but we are making it meaningful for the patient. We have games which patient has to use, and we combine certain exercises together. So in VR, auditory is used, visual is used, proprioceptive, which means they need to hold it. When they hold the certain devices to do it, they are having the proprioception involved as well. Further down, please. Further down. Bawah lagi.
Miss Sarmila, you already co-host if you want to share.
Yeah, that would be great.
Yeah. Sorry for the late. Yeah.
No worries, no worries. Hold on, yeah. Okay, I'll just, but I have to share the entire screen, so just bear with me. Okay, is it visible?
Yes, it is visible.
Okay, so yeah. Okay, so VR, virtual reality in neuro rehabilitation. You can see what happens over here. Okay, there is a video display. Okay, there are some sensors that's attached to the patient's body. Okay, and I want you to see what is happening inside the video game, which is more interesting. Inside the video game, the patient is bounded by the wheelchair, but the task is they have to lift something and they have to keep it on the shelf. So what is happening here is that they're making it more functional. So like it or not, it becomes fun because you're doing it as if in a game, but unknowingly you are exercising. Of course, this is fun, but it comes with its own cost. It is expensive a little bit. And I want you to see the next study. Look at this geriatric patient. She's having fun. Okay, she's having a headset. Okay, and she's having the stimulator here, and it is in a way telling her what she has to do in the video game. So she is doing the exercise, but she's not really exercising. So she's having fun, right? So for the evidence-based practice for this, okay, kita boleh nampak ada evidence. Memang it's just a video game. So you can ask me, oh, but do we really have evidence it is effective or not? You can see, yeah, VR improve arm function, improve walking speed, improve the activities of daily living, okay, have improvement in the balance. Okay, there is also there is an improvement in mobility, which means whether they can walk or not. And you can also see here, it was demonstrated that the robotic-based rehabilitation system combined with the VR and trained several brain areas, which means it is happening at the level of cortical function itself. So moving on to the next one, this is for you to look at it later,
But why am I convincing you is, although it's a video game, but it is a video game designed for exercise purpose. So that is why you can see improvement in balance and gait. Okay, there are even cognitive benefits, psychological. It's more fun, right? So if you're a young person who get, stroke, touch wood, so you are hoping that you get exercises which are fun, but at the same time which are meaningful to you. Okay, so therefore we are referring to virtual reality, yeah, could be used as effective tool to motivate patient, okay, during rehabilitation session. Okay, so that is one good thing why we have to encourage patients for virtual reality or even circuit class therapy. So this is something we did back in UKM. This modul penjagaan di rumah bagi pesakit stroke kurang upaya teruk. So what we did is basically whatever yang kita bincang tadi, ya. We talked about getting the patient to do circuit class therapy, video game and etc. Tapi kalau patient saya, patient yang memang bedridden, dia dapat stroke, is hemorrhagic stroke, is very severe. Patient is bed bounded. What do we do? Right? So we cannot say, oh, we have to just put them in hospital. We have to let them be in the hospital until they recover. No, it doesn't work that way. Why? Cost is one thing. Whether they have the caregivers to look at it is another thing. So what can we think of here is to provide a module. This is a module that we did in the year of 2015, which talks about caregiving module. I am not going to read the points, do not worry. Basically, dalam module penjagaan, in this stroke caregiving module, we give them, okay, how do you feed them? If you have, okay, how, let's say a patient is having swallowing difficulty, need the Ryle's tube. So how do you feed them in the Ryle's tube? So let's say patient, doctor say don't have to put Ryle's tube, but doctor says, okay, you have to go for a soft diet. So we are teaching them how to prepare the soft diet. Do we blend it? Do we cut it? Do we dice it? Do we mince it? What sort of diet? So this module that we prepare here back in UKM is a module we teach our caregiver from the psychologist point of view, from the nurse's point of view, in terms of wound caring, if there is a pressure sore, in terms of physiotherapists. We put it all in the bed. We put it all in the module. So what they can do on the bed for the patient. So that is why if you see on the picture here, we have one from the diet, okay, we have one from the nursing care in terms of, let's say if the patient has phlegm, what kind of things that we have to do. And then of course also we have from the physiotherapist. A clear explanation module is there readily available for our patients in community setting. So don't think that we are only looking at patients who can walk, who can, be function. We are also looking on how to care for patients who are severely affected because of the stroke, right? So this is an article, Nordin et al. Professor Nordin, she is the one who created this particular module that you have seen earlier. So in 2019, she published this study, and the study said that the home-based carer-assisted therapy is as effective as a hospital-based therapist delivery, which means to say, modul ini mampu untuk replicate whatever you are doing in hospital back to the community for someone who is severely affected with stroke. I'm already in the last slide. Do not worry on that. Okay, so I have been going on and on about circuit class therapy. We have a module. Okay, we also have the VR, the video games for our patients. Now, do we have an association? Do we have a community-based center? We have this thing called NASAM. You can just Google it up later. National Stroke Association of Malaysia, NASAM. It's a community-based center. Okay, basically they want to have it in all the state. We have in all the state of Malaysia, we have this NASAM, including our Sabah and Sarawak. Okay, so basically their goal is to have a community center where our patients can go, because not everyone can do it at home. Some people, they find it more interesting if they actually go to a center, a community center. So NASAM is what we have, and a little bit of the pictures back in NASAM. You can see that we do not just target with someone who can walk. In NASAM, we also have
someone with wheelchair, we rehabilitate them. And you can see both the pictures here is representing group exercise because we believe it should be fun. Patients want to come back, they need to have a factor. Why I should go to my therapy? Oh, I want to meet my friend. I want to have a chit chat session. I want to have a competition with my friend. So this is the aim of this community-based rehabilitation center. And you can see here, even though they work in group, every group has their own therapist that is supervising them, looking at how they do, correcting them. Okay, because remember, they also have to do it correctly, right? So these are my references. Okay, so if you want to just have a look a little bit about a certain reference which I couldn't explain in more, I've just put in here for you to refer at. And if you want to reach me, this is how you reach me. This is my email address. And with that, I thank you for the opportunity provided to me. Thank you very much.
Thank you very much. That was an awesome presentation about physiotherapy. For all the participants, we will start the discussion session. For those of you who want to ask directly to Ms. Sarmila, you can raise your hand, or you can also type your question in the chat box. Is that NASAM is non-profit organization or by the government?
It's NGO, non-profitable government. Yeah.
So you are one of the what?
No, I'm not. I'm not.
Oh, you're not.
We do research. When we do research, we collaborate with these NGOs because, like what we say, we have to give back to the community. So we are highly associated with them in terms of research. But I work in University of Australia.
Yeah. Okay. Is there any participant who want to ask question to Ms. Sarmila? So as physiotherapist, do you, I just know because I'm not physiotherapist. So you also assess for patient biological factors, something like that, psychological factors, something like that?
Yeah, we not more of psychological, Ms. Ira. It's mainly for in terms of medical. We look at their, let's say, if they are in a ward, we look at their ABG analysis and we actually decide if this patient is fit. Because when we do certain exercise, which requires a cardiovascular fitness, we have to see whether the SpO2 level is fit enough, whether they are hemodynamically stable for us to actually move them around. But we don't do any active management, but we have to take precautions with that. Yeah.
And in Malaysia, because in Indonesia, I know that we don't have physiotherapists that work in the community like nurses. In Malaysia, do you have physiotherapists that actually go into the patient's home, something like that?
Oh yes, it's actually it's a common practice in here.
Oh,
We do have like what I say, Nasan is actually we have about 13 branches all over Malaysia, and yes, physiotherapists work there full time. And some what they do is they do house calls. So which means the patient, once they have discharged back home, they engage in the physiotherapy service, which physiotherapist goes to their home probably 3 times a week. Yeah, to treat them. Yep.
And is that part of the hospital service or just the personal physiotherapist?
We do have from the hospital itself because sometimes not all the patients can come to the hospital because of they do not have the transport or they do not have the kind of service. So in that cases, even the physiotherapist from the hospitals goes to them. But mostly, I would say majority is the freelance physiotherapist who goes to their house. Yeah.
And then pay directly by the family.
Engage, yes, correct. Engage directly by the family, correct.
So do we have any participant who want to ask question? Maybe Ms. Anggun. Ms. Anggun is ready because she's already opened the video. Maybe.
Thank you, Miss Ira. Good afternoon, Miss Mrs. I call you, Mrs.
Sarmila. Yeah, Sarmila will do. Yep, yep.
Yeah. I'm glad to meet you today, and it's nice to listen your lecture in this afternoon.
Thank you, Ms. Anggun.
Yes. I want to explore more about the collaboration, yeah, between the physiotherapist and nurse, because we are nurse, yeah, to handling a patient with um, um, mobilization disorder, yeah, maybe. Can you explain or share to us how is the collaboration between physiotherapists and nurses in the Malaysia, uh, whether in community or in hospital?
Yeah, that's great. It's a very good question, actually. So we deal more with nurses actually compared to the medical doctors. I'm not sure if that's the practice over there, but in here, in terms of medication modification, the stroke patients, the stroke survivors can directly deal with the nurses in terms of the dosage of the medications and etc. But in terms of how do we therapists communicate with the nurses in terms, for example, secondary complication prevention. For example, if there are presence of pressure sore, we are not in a position to teach them the wound care, for example. So in that case, we need the nursing collaboration, because if the wound care, if there is a wound which is not supposed to happen in terms of pressure sore, and if that is not contained and if that is not healed, we cannot further our rehabilitation. So in that one aspect, we need nurses. The second aspect is whether the patient is actually stable to be moving about. We have a rehabilitation stage where we need a certain criteria to meet. For example, this week I need to make my patient to at least sit by the bedside. Nurses will be able to tell me whether my patient is safe to be able to walk, because they are looking at the blood charts. They are looking at all the facts and figures, whether the patient has any other complication. Because when you say stroke, they won't just have stroke, they will have diabetes. They would have hypertension. Whether they are stable in that factors, which we therapists may not be really aware. So in the case of whether we can progress to the next step, that we need the collaboration of the nurses, number one. And number two, when there are some conditions, like for example, I've mentioned the pressure sore, we need the role of nurses greatly. Yeah. Hope that I clarified on that. Yeah.
Okay, nice. Okay, so in reality, if there is a patient that need some rehabilitation program, do you always work solely or solitary, or work together? And who is the team leader? Maybe is it a physiotherapist or nurses in your country? Yeah.
Yeah,
That's
so yeah, that is a very good question actually. The clash of interest, can, because here, okay, by book, we are looking at patient-centered outcome. Patient is in the center where we are all around them. But in real practice, what I'm saying could be misleading. But we do not have the autonomy of practice yet, which means we are not in a position where we can decide things yet, at least in Malaysia. I'm not sure about other countries. We still take referral. There are some cases where we can directly act, but in hospital, we need the referral from the medical doctors. So we can't say we are the leader, but what I would say is that we take referral from, let's say, from the medical doctors. When we walk into the ward, when the nurses refer a patient to us as a part of medical team, we take in the advice, but we do our own set of assessment to see and decide whether what is referred to us is suitable from our side before we can proceed. So I would not say who is the leader and who is the team member. I would say we should focus, patient is in the center, and we take each other's help to get patient better. But to answer your question, Ms. Anggun, without any polishing, we are not able to work as a soul yet. We have to take the order, yeah, from our whoever our bosses are. Hope that
even
helps.
even in the community setting. Even
Okay,
in the community setting.
in community setting, let's say if patient wants to be discharged and they want to go into NASAM, let's say, they need a referral from the doctor saying and explaining what has happened. Because we can't take in the patient just like that. We need to know what type of stroke it is. Is it ischemia? Is it hemorrhagic? And the patients might not be able to tell if you ask them what type of stroke you have, right? They'll be telling, oh, this is stroke, but we want to know what kind of stroke. And that can only come from a medical report. So they might not have a referral letter, but at least they should have a medical report telling what were the condition like before we take in, for further actions. Yeah. Hope
Yeah,
that helps.
I'm really interested with this topic because stroke is one of the most common disease still in Indonesia also. And in Indonesia, as I see, the patient with stroke has a long recovery. How about in Malaysia? It take years to be able
Yeah,
to
2
just
years.
walk again. It's the same.
Yeah, to be honest, some when we see a younger population who have the interest and the drive to recover faster. To be honest, my youngest patients, we have seen recovery within 6 months. They're able to walk at least with a quadruped. Of course, we're not looking at perfection, but they're able to walk. But for some, we take 6 months just to get them stable, get them in standing. So there are a lot of factors, Ms. Ira. So I think 3 years, I've even seen patients coming in for outpatient department up to 3 years just to get better. So I think it's common, right, to have a very long recovery. Yep.
Maybe my last question from me before maybe someone will ask you. Do you educate or do you train the family to do a small exercise? Because as you say before that the physiotherapist cannot go every day to the patient's house. What kind
Okay.
of activity?
So, okay, in Malaysia, let's say we are seeing, if the doctor has decided to discharge the patient, he would make sure that the therapist visits the patient at least once and provide them the patient education. So the therapist is supposed to tell to the patient and their caregivers what they should be doing at home. And then what we are going to do is that we are going to take them in back to our outpatient department. So even though they have been discharged from the inpatient with the patient education and home exercise program, we'll be taking them back to the hospital as outpatient. However, some patients, they prefer to do it at home. In that case, we will be doing home visits, number one. Or number two, if they prefer to be in a home, a community-based center, we will provide them a referral letter on where they want to go and have their rehab for. So yeah, that's what we will be doing. Hope that answers Miss Ira.
Yeah, thank you. We have one question from Tia. Which is better in the rehabilitation of stroke patient, core stability exercise or conventional exercise?
Very good question. Okay. When you talk about core stability, we have to understand this is not musculoskeletal. This is not a low back pain patient where you're only focusing on core. What kind of core stability exercise that we're looking at? If I'm saying, okay, I put my patient on a gym ball and I ask my patient to sit on the gym ball and I just push the gym ball in all the direction, which is challenging them because they have to make sure their abdominal muscles are tight so that they don't fall. That is a core stability exercise. But my question is, how much we anticipate this in our real life? Another core stability exercise I can think of is the one that I showed in station 5, where my patient has to be standing and my patient is able to reach for the donut and put it in the yellow string in the middle. That is also training my core because as I reach forward, I need to contract my abdominal muscle to put it in the the yellow string where you saw earlier. So what is the idea here is whether it be core stability exercise or whether it be conventional exercise, the rule of thumb is it has to be functional to my patient. How much the patient can replicate in real life. If let's say your core stability exercise that you are talking about is my patient is standing, okay, and I'm pushing my patient in all the direction and my command to my patient is stay still, do not let me push you. As I push you, I want you to contract your abdominal muscle and remain still. That is one of the core stability exercise, and that is actually functional. That is even better because let's say they go into a train station where a lot of people will be pushing them and they have to balance themselves. They will be using this principle where you have taught them in the center back in their real life. So if you ask me whether core stability or conventional, I would go with core stability provided it is functional exercise based core stability. I hope I've answered you, Ms. Tia. Have I?
Miss Tia, have the question answered? Yeah, I think so. So, do you have any more? Yeah, do you have any more question? No more. Yeah, no one raising their hand. Maybe yeah, because you are very.
Hopefully it's a good one.
Yeah, because it's really interesting and the audience has understand the lecture.
Thank you.
So yeah, that was really interesting lecture and discussion, and I personally exciting to hear more from you maybe in the next future.
Sure.
Yeah.
Thank you.
Thank you very much, Miss Sarmila, again for sharing with us today, and thank you also for all participants who has asked questions and also listening to our lecture today. For the next agenda, will be covered or will be handled by the Miss Siva. Miss Siva, yeah, the time is yours. You can continue the agenda for today. The discussion is finished.
Thank you, Ms. Ira Rahmawati, as moderator. Okay, now I inform you that the distribution of new certificates will be distributed minimum 3 weeks after the event. And for all participants, I remind you to fill in the evaluation link before the event is over. And now, the next agenda is documentation session, and will be led by Kak Regina.
Okay, thank you. I will lead the documentation session. Please turn on the camera and sit down properly. Please turn on camera. Start from slide 1 in 3, 2, 1. Slide 2 in 3, 2, 1. Slide 3 in 3, 2, 1. Thank you.